Happy New Year to you, and thank you for joining us for our third installment of Siteman Learning with National Leaders, presented by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. Good evening to you. I'm Carol Daniel, your host for tonight. Tonight's discussion will center on lung cancer. We'll be focusing on the importance of screening, the risk of smoking, and lung cancer therapies. Now, let me say quickly that normally there'd be a party going on right here in the studio, but because of the variant, our doctors are joining us virtually. We are still going to have an incredible conversation, but we will not be here together. Let me start with some statistics for you. Did you know there are more than 235,000 new lung cancer cases in the U.S. in 2021? Lung cancer is the #1 cause of U.S. cancer deaths. Lung cancer screenings could save 10,000 more U.S. lives each year. And quitting smoking will lower a person's risk of lung and other cancers, heart disease, stroke, and early death.
Keep going.
Siteman Cancer Center is an international leader, in cancer treatment research, prevention, and education. Its renowned Washington University physicians treat 70,000 patients each year in 6 locations across Missouri and Illinois. Joining us tonight, surgical oncologist Dr. Viram Puri, medical oncologist Dr. Brett Herzog, and radiation oncologist Dr. Jason Lee. Doctors, thank you for joining us tonight, and thank you all for being with us this evening. And quick reminder to our viewers, you can submit your questions right here on the website, and we'll try to get those answers for you throughout the evening. Let us begin with the new cancer screening guidelines that went into effect last year.
If you are thinking about getting screened for lung cancer, there are 3 things to know. You must be 50 to 80 years old. If you are a smoker, you must have smoked at least 1 pack per day for 20 years, or 2 packs per day for 10 years. You also may still qualify even if you quit smoking, but you must have quit in the last 15 years. To find out if yearly lung cancer screening is an option, make sure to talk to your doctor, review your pros and cons, and then decide what is best for you. Always talk to your healthcare provider when it comes to any questions regarding screening, or contact Siteman Cancer Center at 314-747-3046. If you are still a smoker, know that quitting is the single most important step in preventing lung cancer and other diseases of the lungs, heart, blood, and brain. Call 1-800-QUIT-NOW to talk to a trained counselor, or text Siteman to 47848. And remember, if you want any more information about lung cancer screening, go to siteman.wustl.edu/lung cancer screening.
We'll be talking about smoking and even vaping in just a few minutes. But first, a couple of more questions about screening. Let's start with Dr. Puri. Can you tell us about the main benefit from lung cancer screening?
Thank you, Carol. Screening is defined as trying to detect a disease process before it has become apparent in its natural history. And it's applied to many disease processes. For example, patients may be screened for cardiovascular disease, or women are eligible to be screened for breast cancer after a certain age or depending upon family history. So over the last 2 decades, we have conducted as a group of oncologists, surgeons, physicians who take care of patients with lung cancer, a number of trials which have shown that if you detect lung cancer at an early age, in a pre-symptomatic situation, in a group of patients who at baseline are at a higher risk than the average population of developing lung cancer, then you can make a substantial difference in their likelihood of dying from lung cancer and decrease that in a significant way. The key here is to find lung cancer at a point where it is in early stage, where it can be offered potentially curative therapy. So very briefly, I'll tell you about sort of the 2 main trials that have prompted lung cancer screening to be adopted. One was the National Lung Cancer Screening Trial conducted in the United States between 2002 and 2004. About 53,000 patients were enrolled in this trial, and half the patients underwent CAT scans, the other half underwent chest x-rays, And it was noted that in the group that underwent chest CT scans, the likelihood of dying from lung cancer was substantially lower. And the same findings were replicated in a very large study in the Netherlands called the Nelson trial, the results of which became available about a year and a half ago at this point in time. So both of these large studies have shown that if you are able to detect lung cancer at an early early stage through screening mechanisms, which is essentially a CT scan, you can significantly lower an individual's likelihood of dying from lung cancer, or in general, the overall risk of death in that individual.
We have heard that in all of our conversations, early detection. But Dr. Puri, can you describe the procedure? Some would want to know whether it is invasive or is it just an imaging procedure?
Well, yeah, it is not invasive at all. It is an imaging procedure which can be done completely painlessly. The test is called a low-dose CT scan. So it's differentiated from a standard CT scan, which usually delivers, say, an amount of radiation, which by numbers is between 7 and 15 millisieverts, which is just a unit of radiation that is delivered by imaging studies. This test delivers 1.4 to 1.5 millisieverts of radiation, so about 80% less radiation than a standard CT scan. The test itself takes under a minute to do, but the entire process takes between 30 and 60 minutes for patients to sort of check into the radiology facility, change into a gown, and be introduced to the CT machine and their techs, and then undergo the procedure. The procedure is performed in a machine called a CT scanner, which is a helical machine. It's sort of like a spiral, which spins around the patient and takes an image of the entire body in 5 to 10 seconds in one breath hold. So patients hold their breath for 5 to 10 seconds, and the scan is done in that period of time. They have to lie still so that they get good images taken of their entire body, particularly the chest, while this is being conducted. And the images can be quickly interpreted by a radiologist, usually within a few hours. There are no IV dyes administered, so there's no intravenous injection performed. And so it's a completely painless procedure.
Dr. Herzog, let's bring you in. What happens if something abnormal is found? What next?
It's a great question. So depending on what we find, we may actually recommend a follow-up CAT scan in a few months' time, or we may recommend getting a sample of that tissue, something called a biopsy, where we're actually taking a piece of that tissue to look under the microscope to see whether or not it is a type of cancer. Because not all findings that we find on CT scans are cancer. And so I think that's important for people to know that it doesn't always mean that something is found that we're immediately going to put a needle in and trying to find a sample of that.
Can you repeat that last part? Because I think that's worth repeating. People are so afraid of what might be found that they don't even get the test in the first place. And you said not everything that is found is
cancer, and that's right. And sometimes it takes time to figure out if these things that are relatively small sometimes, if they're going to grow over time. And so sometimes we need to watch them to see how they behave. And so it's not always an indication that you have to get a biopsy of that.
A quick reminder for our viewers, if you have any questions about screening, you can submit that question right here on the website. So they'll let me know if we have any questions when they come up. They'll let me know. So as we saw in that piece, smoking and even vaping are major risk factors for lung cancer. In fact, in October, the Food and Drug Administration announced that it would allow that the marketing of e-cigarettes would end. Dr. Puri, why that announcement?
E-cigarettes, or what they're formerly known as, which is ENDS, called electronic nicotine delivery systems, have been around for a number of years. However, about 2 months ago, the FDA approved 3 specific e-cigarettes for direct marketing and promotion. These cigarettes are differentiated from all the other e-cigarettes out there because these are nicotine-flavored or standard cigarette-flavored e-cigarettes. So they're different than e-cigarettes, which the media and the general public has thought has been marketed aggressively to our youth. And the main reason that the FDA has approved these 3 particular products is to allow smokers to cut down on their cigarette consumption or use these as aids in completely quitting smoking. There is a large body of literature which shows that a number of electronic cigarettes or other forms of nicotine replacement can help heavy smokers either cut down the amount of cigarette smoking that they're currently doing or completely quit smoking. So this is a step by the FDA to try and promote these as nicotine replacement therapies and aids to quitting.
Dr. Lee, you're nodding. Did you want to add something?
No, I think Dr. Puri hit the nail on the head. The FDA's primary goal in approving these e-cigarettes or ends was primarily to help with current smokers try to either bridge them to completely quitting or to reduce the number of cigarettes that they're actually smoking. There obviously was some controversy about the actual approval of this, but the evidence does show that being able to offer these particular products to current smokers in an effort to reduce their cigarette consumption is beneficial to their long-term outcome.
We have a couple of questions I'm going to get to in a second, but I want to stay on the e-cigarette issue because I know there are loved ones listening who want to know, are e-cigarettes really safe, or are they at least just safer than tobacco?
So I think that at this point in time, it would be difficult to conclusively give an answer to that question. However, the way I would think of it is that cigarettes are a combination of an agent, which is nicotine, which is a chemical agent, which is accompanied by tar and many other chemicals within cigarette smoke, which have been shown to be carcinogenic. Nicotine itself is an addictive chemical, but a significant portion of the harm from cigarettes is not just related to the nicotine, but to all the other chemicals that are present in cigarette smoke. So theoretically, if one were to be able to deliver nicotine without all of the other harmful potential chemical agents which are present in cigarette smoke, then one might think that, yes, that may be a safer way for any individual to consume nicotine. However, there are really no good data for any long-term studies showing that the e-cigarettes are significantly safer than cigarettes. That being said, in the short term, we have several patients say if they're preparing for an operation and they want to use e-cigarettes for a brief period of time as an aid to come off cigarettes, which have a higher risk of complications associated with any major surgery, we actually will say, yes, that's okay to go ahead and do that. So although there are no long-term data, it is likely that at least in the short term, that e-cigarettes may be less harmful than cigarettes.
Rachel and Jenny, we'll get your questions next, but we've all heard for years how bad smoking is. I think that most people know that, but let's talk about specifics. How much impact does smoking really have on the entire body?
Carol, would you like me to address that?
Yes.
Okay. Well, smoking has, I would say, an outsized effect compared to pretty much any other environmental exposure that people can have. So cigarette smoking causes nearly or contributes to nearly 500,000 deaths in the country annually. Mm-hmm. And the smoking-related health risks or health problems occur in pretty much every organ system in the body. So smoking can cause stroke, coronary artery disease, can elevate patients' blood pressure, can significantly increase the risk of respiratory disease, which is emphysema or chronic obstructive airways disease. A number of cancers in the body, not just lung cancer, head and neck cancer, but blood cancers, colon and rectal cancers, kidney and ureter cancers, larynx cancers, pancreas cancer, they are all related to smoking in some way. So the risk of these cancers increases in patients who are smokers. Not only does it affect people who are sort of older, smoking can also affect younger individuals, particularly people of a reproductive age. It can decrease both the risk of what's called preterm delivery in pregnant women, also increases the risk of low birth weight babies. So there are numerous body systems which are adversely affected by smoking.
Let's get a couple of questions from our viewers, and you can leave your questions right here on the website. Going to Rachel first. Rachel asks, what is the average age of your patients, and what are some of the first questions you hear from your patients once they are diagnosed? Dr. Herzog, can you jump in on that one? And we can get answers from our other panelists as well.
Yes, so the vast majority of our patients are going to be diagnosed somewhere in the age range of 65 to 75. That's the typical group of people that we see. And I think one of the biggest questions that people have is, well, now what do we do? I think people hear the word cancer and they often are very scared when they first come in to see us. They're very worried about what that entails and what that means. And so most of our time is spent kind of laying the groundwork for what is really a relationship that is developing, that will develop over time, about how we're going to address this together.
Jenny says, long-time listener, first-time caller. I love that. And says, I've never smoked a day in my life, but grew up around secondhand smoke. Am I at risk? Should I be screened in any way? Dr. Puri?
So unfortunately, secondhand smoking does increase an individual's likelihood of lung cancer compared to someone who's a non-smoker. However, the risk in smokers themselves is significantly higher than those who have just been exposed to secondhand smoke and are not smokers themselves. So although the risk is higher than the average population, it is nowhere close to the elevated risk of a true smoker. So that was the first part of the question. And secondly, in terms of screening, currently, there are no universally recognized guidelines for someone who has significant secondhand smoking exposure for screening. And the decisions for individuals who don't fall in those guidelines are made on a case-by-case basis. And these the factors which go into making such decisions include, just like you asked, secondhand smoking exposure, strong family history, or other environmental risk factors such as radiation exposure, which can elevate someone's risk for lung cancer. Also, there are certain genetic mutations, etc., which elevate individuals' risk for lung cancer. So outside the guidelines, the decisions for screening are made on a case-by-case basis.
Here's another really shocking statistic for us. We know that on average, smokers die a decade earlier than non-smokers. Let's talk about the other conditions that smokers may in fact face. Dr. Lee, can you answer that as well as Dr. Puri?
Sure. I think Dr. Puri touched upon a lot of those conditions a little bit earlier in the segment. Smoking not only, today we're talking primarily about smoking and its impact on lung cancer, but again, Dr. Puri had already mentioned smoking's impact on general cardiovascular health, risk of cancer in other parts of the body. Smoking has, I would say that smoking is one of the biggest, one of the most impactful factors that people have control over in terms of general health. And being able to quit smoking or reduce the number of cigarettes you're able that one smokes can have a pretty outsized impact on both day-to-day how you live, and just as important, how long you would expect someone to live with or without smoking.
Dr. Puri, is there anything else to add to that? The other conditions that smokers face?
I think that it is very important to understand that the benefits from quitting smoking start accruing pretty much right away. And people think of cigarettes as sort of a lifetime accrued risk that they have developed, say, with years or decades of smoking. But the advantages of quitting smoking start very quickly. And this is from large studies. So when you look at entire populations or communities where smoking has gone down either by legislation or community programs which have decreased the likelihood of smoking, and the risk of cardiovascular disease, myocardial infarction, so basically heart attacks or other causes of cardiovascular mortality, they come down extremely quickly in those communities. And any individual's risk of, say, heart attack or other cardiovascular disease such as stroke comes down very quickly within a period of months. while long-term, the impact is on factors such as lower likelihood of cancer occurrence. So I think that's very important to understand.
It's so crucial to know that the body begins, I'm going to use the word a healing, that benefits happen immediately after you quit smoking. That is just so crucial to know. So let's talk a little bit about that. Quitting lowers the risk of nearly all diseases, and over time, the risk of some can even drop to that of a non-smoker. So let's talk about those who want to quit. What advice do you have for them? They've tried to quit, they have failed in the past, maybe they aren't sure what they can do now. Dr. Herzog, you want to jump on that one?
Sure. So don't give up. We have a lot of professionals that are willing to help you. This is obviously a very important thing from our side, because if we're able to cut down on the amount of smoking that people are doing or eliminate it completely in their life, we know that over time, that their risk of developing these types of diseases drops dramatically. And so it's in our interest to try to help them do that. And so we have a lot of different ways of doing that, and to simply ask. And if something hasn't worked in the past, that's okay. We can try something else. There are a lot of different ways of going about trying to quit. But simply because you've not been able to do so at one point doesn't mean that we shouldn't try again.
Dr. Lee, can you add to that? I mean, there are lots of people listening. They either are smokers or they know someone who smokes and they would like them to quit. What is the advice that you have given to those who've tried to quit before, or this might be the first time that they've tried to quit?
Yeah, I'll echo what Dr. Herzog said, which is that it never hurts to try and try again. A lot of the difficulty with quitting smoking is biological. Smoking, there's a physiological reason why it is difficult to quit. And so I think it's important to try to understand that there can be feelings of despair or disappointment with oneself if you've tried and failed. But understanding at least that part of it is biological, and that it is a physiological addiction to cigarette smoking. I think I tell my patients that because that there's that biological component to it, they shouldn't blame themselves if they're unable to quit. A lot of it's in their control, but some of it isn't. So try again. And I would also add that it's never too late to quit. Dr. Puri had talked about the benefits of accruing immediately. Cancer specifically, we know that even at the time of diagnosis, there have been a number of studies, but more recently published studies have shown that quitting smoking, even at the time of diagnosis of lung cancer, dramatically improves the chance of living longer. In some studies, the benefit is about 10 to 20% improvement in survival at 5 years out from diagnosis. So, like I said, never too early to quit.
Dr. Puri, I've told you guys this story before we started our discussion tonight, that my father was a smoker. He's 90 years old now. And I want to say he tried to quit. It might have been 7, 8, or 9 times. I lost count, but eventually did quit. And I'm just his daughter, so I didn't give him advice. His doctors were telling him to quit, and eventually he did. Dr. Puri, what advice do you have for people who are trying to quit, or people like me as a daughter? I wish I would have said to my dad, thank God he did stop. But, and I will say this, I did say to him that I didn't like to get in the car with him when he was smoking. And that wasn't advice, but it was something that did let him know that we loved him and we didn't want him to smoke any longer. So that was all that I could give as a 16-year-old to my father. But what advice do you have for us, Dr. Puri, who are even trying to help our loved ones stop?
I agree with everything Dr. Herzog and Dr. Lee said earlier. And I'll add maybe 2 points, one data-based and one anecdotal to the conversation. When we, as a group, evaluate patients and figure out who is more likely to quit than others. In the past, if a patient has tried to quit and failed, that significantly improves the chance of that person being able to quit in the future. So past unsuccessful attempts are actually prognostic, show that you have willingness to at least attempt to quit, and you are more likely to succeed in the future. So past failure is a sign of future success. That's one. Secondly, for the smoking cessation, particularly say for patients who have been recently diagnosed with lung cancer and I am seeing for potentially evaluating them for an operation. I use scientific data, some of which has been generated by studies done by our own group. And we have noted that in patients who continue to smoke coming in for a major lung cancer operation, and when we compare them to those who have even quit smoking 3 weeks or more prior to their operation, the likelihood of lung-related complications or pneumonias in the post-operative period is significantly improved in patients who are able to quit even for a few weeks prior to surgery. So that gives patients an important incentive to try and quit in the preoperative period. And secondly, I use what I think of as a team approach. And I tell the patient that the patient, their family, and us as their caregivers or their healthcare providers are a team. And we want to optimize that patient's chances of doing well with an operation. And that gets buy-in from the patients that they want to improve their post-operative outcomes, avoid the risk of complications. And from our perspective, we offer a number of tools, including nicotine cessation, smoking cessation counseling, or other tools that we have in our arsenal to try and help them quit smoking.
I'm so happy that we have a lot of questions from our viewers, so let's get through some of those. I think it's John who asked, do all kinds of smoking cause cancer? Cigars, cigarettes, hookah, marijuana, do all kinds of smoking cause cancer, Dr. Puri?
Most of the data that exists is for cigarette smoking. But other forms of nicotine inhalation or nicotine smoking, be it cigars, are also known to be associated with cancer. The association between marijuana smoking and cancer, particularly lung cancer, is much less clear. So I'm not certain that one can conclusively say that there is evidence for that.
What symptoms should we watch for that might be warning signs of lung cancer? Dr. Herzog, can you take that one?
Sure. So I think one of the big ones is a new onset cough, or obviously if you've started coughing up blood recently, that is something that we are very concerned about. That should bring you to our attention relatively soon. I think one of the other things is shortness of breath that's new, something that you were able to do a few months ago that you're no longer able to do, is something that's a little bit of a red flag. And then I think one of the other things that we get concerned about is whether or not there's significant weight loss that's occurring. And so that's something that we are watchful of.
All right, Rebecca, thank you so much for that question. This next one from Kyle, are there support groups, services, even holistic therapies, such as hypnosis or acupuncture, that you recommend to help people quit? Dr. Puri, you want to take that one first? And then Dr. Lee?
I'm not aware of any recent data which shows that acupuncture may be beneficial. However, I'm not certain that I've kept up with the literature for that specific aspect. However, the therapies that are available within the Sightman Cancer Center include smoking cessation counseling, nicotine replacement therapy, using other medications which can diminish the urge to smoke. So those are therapies which are available. However, if patients are willing and eager to pursue other non-traditional forms of nicotine cessation, then that in of itself indicates that they really want to quit. And if there is any recent literature that may have come up, I would be happy to sort of look that up and add that to our arsenal for nicotine cessation.
Yeah, generally speaking, I'm in favor of patients making every effort to try to quit smoking. Even if there is a lack of data for a particular modality for quitting smoking, as long as it has no apparent harm to the patient. I'm personally an advocate of trying, every every sort of method that's available to a specific person. Obviously, with the consultation with the physician to make sure that those wouldn't interfere with any therapies or the rest of their medical history or health.
Is lung cancer genetic? That's a really good question. That's from Rebecca. Dr. Herzog, Dr. Puri?
Yes. So what we know about lung cancer is that for the vast majority of patients, lung cancer is not genetic. But we do know that there are certain syndromes that are familial that do increase the risk of developing lung cancer. And so, like Dr. Puri mentioned earlier, in certain instances, that contributes to whether or not those patients should be screened. And so I think that's really important to recognize is those patients are often already aware of that diagnosis in a family member. And so that's something that they can talk with their primary care physician about letting them know so that we can stay on top of either screening for them or keeping a closer eye on them.
We should
I
mention—
agree with everything Dr. Herzog.
Dr. Puri, go ahead.
I was just going to say, I agree with everything Dr. Herzog said.
Thank you.
Nothing else to add.
We should mention that we do have links to smoking cessation programs at the American Cancer Society and Siteman Cancer Center in our follow-up email that all viewers will receive after this live stream. We will also have a link to Siteman's free online tool that helps you determine your risk of 12 cancers. It's called yourdiseaserisk.com. That's yourdiseaserisk.com. Now, let's turn to lung cancer in people who have never smoked before. 10 to 20% of lung cancers happen in those who have never smoked or smoked less than 100 cigarettes in their lifetime. Dr. Puri, are the symptoms the same in an individual who's never smoked or smoked a little?
Yeah, unfortunately, the symptoms are same for lung cancer in smokers and non-smokers. However, the one thing that may distinguish the symptoms to some degree may be that smokers often have a chronic cough at baseline. However, a new cough that develops in a non-smoker would be thought to be more of a reason to investigate a problem relatively quickly compared to a smoking population. That's one thing which is different. The one thing I also like to add is that one should not be overly reliant on symptoms, because in the vast majority of patients where we detect cancer at a curable stage, that means early stage lung cancer, the lung cancer is not symptomatic. And these cancers are picked up on either a screening CT scan or what we think of as an incidental CT scan, that they're undergoing a CAT scan of the chest, or sometimes even in a CAT scan of the abdomen, the lower half of the chest is included and part of the lungs are visualized, and cancers get detected that way when they are at an early stage and really do not produce any symptoms.
We did get a question about marijuana, other types of smoking. We have a question now. It is anonymous, and that's quite all right. What about dipping and chewing tobacco? Can that cause lung cancer? And is that safer than smoking? Dr. Herzog?
So this is a difficult question because from a lung cancer standpoint, there's decreased risk compared to cigarette smoking. However, the unfortunate thing with dipping is that you put a lot of these carcinogens in direct contact with the surface in the mouth, the mucosal surface. And so this actually increases your risk of developing a different type of cancer, but along the same kind of in your mouth tract. And that can also be significantly morbid, but also deadly for some patients. And so our recommendation is that none of that is good, and eliminating that from what you do and how you behave is as good as you can do. I grew up in a small town in Southern Illinois, and a large number of my classmates would do chew or dip in school. And so as we graduated, that was something that I constantly reminded them of doing, is to stop that. And if they were able to prevent that in their life, that would be very helpful. So
we have another question. Is there a difference in lung cancer between those who smoked and those who did not? We talked about symptoms and the difference there, but the actual lung cancer when diagnosed. Is there a difference? Dr. Puri?
The lung cancer that is seen in non-smokers generally is one specific subset of lung cancer, which is called an adenocarcinoma. And that is sort of when you look at a lung cancer or cancer cells under the microscope, they tend to follow different patterns. And based upon how they appear under the microscope, they are categorized as what we call squamous cell carcinoma or adenocarcinoma or small cell carcinoma. Patients who are non-smokers tend to have adenocarcinomas more frequently than others. Also, these cancers in non-smokers tend to have a somewhat different appearance on the CT scan images when they're detected. There are also certain populations in the world, for example, non-smoking related lung cancers, particularly these adenocarcinomas, are more prevalent in the eastern part of the world, say in Japan, Korea, and China, compared to the United States. But in the United States, we have seen a somewhat gradual increase in the incidence of non-smoker related lung cancers.
Let's turn to lung cancer therapies now. Dr. Lee, as you know, of course, there are different types and combinations of therapy available for cancer patients. So let's talk about what they are and how do doctors determine the best treatment for each patient.
Sure. In lung cancer treatments, there are three general approaches that we consider when someone is newly diagnosed with lung cancer. And actually, all three of us represent the disciplines that would be consulted upon for a newly diagnosed lung cancer patient. So Dr. Puri is a thoracic surgeon, and he operates on patients who might require removal of the cancer. So that's one option is surgery. Dr. Herzog is a medical oncologist who prescribes medication, whether it's chemotherapy or kind of more recent therapies available, something like immunotherapy or targeted therapies. And then, a third general approach would be with radiation, which is what I offer my patients. The decision about what therapy to choose for each patient is tailored upon a lot of different factors. First and foremost, the stage, how advanced the lung cancer is. We also consider a lot of different other factors, things like the patient's age, how healthy they appear, how active they are. And we also take into consideration other non-medical things such as how much support they have at home, how easy it is for them to leave work for a particular therapy. Some therapies may be more advantageous than others, particularly if someone is the sole breadwinner, for instance, for their family. So we take a lot of different factors into consideration to come up with a to come up with a specific treatment approach for each patient that we see.
Dr. Herzog, in May, the FDA approved a new drug that has been shown to help certain lung cancer patients. What can you tell us about this new drug?
Yes, so I believe what you're referring to is something called sotorasib or Lumakras. So this is a therapy, it's a pill that's used to treat patients with what's called metastatic lung cancer, or lung cancer that's spread outside of the lung. And it's the first drug in what we hope, is a group of treatments to be able to help patients with a mutation or change in a protein called KRAS. So KRAS is essentially a messenger within the cell. And so it communicates or helps communicate between two portions of the cell normally. And in non-small cell lung cancer, it's mutated or changed in about 30% of patients. And so in that subset of patients, after they've already completed other forms of therapy, this medicine was shown to provide significant benefit for them. And so it was approved, like you mentioned, last year. And I think we're all very excited about what that portends long-term. I think one thing that people need to keep in mind is this drug this protein, this messenger, was previously thought to be untargetable. When I started training about 2 decades ago now, that was actually considered something that you really couldn't alter or change with a medicine because it affected too many normal cells. But over the last several years, Now, several groups are trying to target that, and we actually have several of those trials here at Siteman.
Dr. Puri, and I want each of our panelists to answer this one, Dr. Herzog and Dr. Lee. What other therapies are available now or in development that you are most hopeful about? Dr. Puri, can we start with you on that?
So I think that what I'm most hopeful for and optimistic about is not just sort of one therapy, but an armamentarium of therapies, which largely come from Dr. Herzog's field, which is taking care of cancer with targeted medications, intravenous oral forms of therapy, other ways of administering that therapy, which can specifically go after something in the cancer cells that makes it unique and with which that cell can be destroyed without harming other cells in the body. Say, even in early stage lung cancer, which is the vast majority of patients that I take care of, when we perform an operation, which we think is a curative operation for that patient, somewhere between 20-25% of those patients, unfortunately, over the next 5 to 10 years, will have recurrence of the cancer. So if one were to be able to find something specific about those small 20% of patients in whom the cancer will come back and target them with a certain agent which will lower their risk of the cancer coming back or significantly diminish the likelihood the cancer will be back, that would be the most exciting development in the field of early stage lung cancer. And for that, I think our basic scientist friends and Dr. Herzog and his colleagues, I look to them for advancements in the field.
Dr. Lee, most hopeful therapy or what's in development?
Right. So I would say that if you look at the field of lung cancer treatment over the last 5 to 10 years, I agree with Dr. Puri, the biggest bang for the buck that we had with treatment options has been in the field of targeted therapy, immunotherapy specifically. You're seeing patients live much longer with what would have been considered potentially incurable disease just a few years ago. So I think it's actually a very exciting time to be helping patients with lung cancer, particularly with what I think are pretty gigantic leaps in our ability to help patients long term. Now, as a radiation oncologist, I have somewhat of a bias, but the field of radiation in general has trended towards being able to deliver radiation therapy much more precisely and being able to limit the toxicity and side effects of treatments to areas of the body that we want to avoid treating. And so I think a lot of the advancements in our particular field are twofold. One, being able to improve what we call the therapeutic ratio, getting higher doses of radiation to a smaller area and at the same time limiting side effects. And secondly, being able to add the radiation in synergy with systemic therapy, for instance, with other chemotherapy agents. A lot of advancements are, a lot of research is being, efforts are being placed into looking at radiation and immunotherapy with, in combination or sequentially. So I think overall, it's a very exciting time to be able to help patients with lung cancer right now.
Dr. Herzog, other than working at the internationally known Siteman Cancer Center and with what appears to be incredible colleagues, what gives you hope?
So, one, working with incredible people, having incredible patients. And then the other thing, we're starting or beginning to learn more and more about how our immune system normally targets cancer cells. And by doing that, we're able to reveal potential ways that we can help harness the immune system to fight off cancer. And I think, as Dr. Puri, Dr. Lee mentioned, this becomes really important in those patients where we early on are able to identify, yes, you have cancer. We're able to treat this either with an intent to cure, but how do we protect them from having it recur? And I think that's something where if we're able to harness the immune system to do so, that's a very exciting thing. Now, obviously, many of these drugs do have side effects, and so it's balancing what that risk profile is with how the patient is going to do long term. And so I think that's one of the interesting areas. And then there are a lot of immune cells that we don't really know much about. And so we're just now beginning to, kind of chip away at the tip of the iceberg, despite many years of work, both by people here and other institutions, at really understanding how to best modulate the immune system to treat cancer.
There are immune cells we don't know a lot about. Now we'll save that for a whole nother discussion one day, because I'm so curious about that. We do have some questions, though, from our listeners before we say goodbye tonight, our viewers. Deborah wants to know the average lifespan for stage 3 lung cancer. Dr. Puri?
I think that's a good question for Dr. Herzog and Dr. Lee.
Okay.
And I'll maybe make a comment at the end of their comments.
Dr. Lee?
So historically, patients who had stage 3 lung cancer, you could quote the survival with non-small cell lung cancer, I should say, non-small cell lung cancer, stage 3 patients going through standard of care therapy, you might expect 20-25% of patients being alive at 5 years. We've bumped that up considerably over the last few years, particularly, like I said, with medications that are available to patients that Dr. Herzog would be seeing in administering these medications after initial treatment.
And so like you mentioned, historically we looked at 20 to 25% of people at 5 years still being alive, and now with some of the new medicines, this is with chemotherapy and radiation, followed by immune checkpoint blockade or immunotherapy. And in those patients, there was recent data that showed that about 44% of patients were alive at 5 years. And so certainly we've moved the bar. I don't think any of us are satisfied with the 44% survival rate at that point. And obviously the goal is to try to understand how to make that even better over time. But like everyone has mentioned so far, as people are tolerating treatments better, whether that's because we're able to target the radiation better or be able to target the cancer better, we have more options to be able to treat people that otherwise wouldn't be able to tolerate the therapy. And so I think this provides benefit to more and more patients as we're starting to learn these things.
We have a question.
Carol, I wanted to add.
Go ahead.
I wanted to add one other thing. I'm sorry. If I were to tell a patient that there's this wonder drug that could improve their chance of survival at 5 years by 10 to 15%, I think most people would jump on that jump on that opportunity. That wonder drug is actually smoking cessation, going back to the initial part of our conversation. So, it's a relatively cheap way, not an easy way by any means, but it's been shown over and over again, very, very good data for this, that smoking cessation can lead to a longer life expectancy. And so I think, you frame it that way, that you have this wonder drug that can potentially improve the chance of you being alive in 5 years by 10 to 15%, makes a pretty good argument to pursue smoking cessation.
That's an incredible marketing campaign that I'd like to take part in. The wonder drug, smoking cessation. Absolutely. Dr. Puri, you said you wanted to add something there, or we have another question as well if you don't.
Very small comment, which is that the majority of patients with stage 3 lung cancer are treated with chemotherapy and radiation therapy. In a very small proportion, which ranges between 10 and 25%, those patients are good candidates for an operation. So again, not everybody with stage 3 lung cancer is a good candidate for an operation. A very small select minority are. But when they are treated with what we call tri-modality therapy, that means a combination of chemotherapy delivered by Dr. Herzog and colleagues, and radiation therapy from Dr. Lee and his team. And then we perform an operation oftentimes after they've recovered from chemotherapy and radiation therapy. That small select group of patients tends to outperform the other 75, 80% or 85% stage 3 lung cancer patients and have superior long-term survival. But again, it's a very small, highly select group of patients who can undergo an operation for stage 3 disease and tend to have better long-term survival.
We have a question now from Michael, who asks, if tests reveal small, stable pulmonary nodules, will they turn into cancer? Dr. Lee, is that for you? Or Dr. Puri?
Sure, I can take.
Go ahead.
Sure, I can take that. So when we do a CT scan and we see what are described as pulmonary nodules, The only definitive way to know whether that nodule is malignant, cancerous, or benign is actually to get a biopsy. But for a lot of these nodules, which are very small, I would say less than half an inch in diameter, it's essentially infeasible to pursue biopsy for a lot of different reasons. So the question of whether that spot can turn into a cancer, well, we don't exactly know what that spot is in the first place, but we have strategies that we employ during surveillance to determine whether that spot in question is indeed cancerous. Repeat CT scans at regular intervals. Sometimes we employ something called a PET-CT in certain situations to give us a little bit more clarity or information about if that nodule in question is concerning. So I would say that in the best strategy for determining whether a specific pulmonary nodule or nodules in the lung are something you're concerned about is just talk to your doctor and have a discussion with them about what those spots actually mean.
Dr. Herzog, as a medical oncologist, you've seen this? Can you answer that question as well?
Yes, and like Dr. Lee said, and this is the truth, we simply don't know when we first see a nodule whether or not that's cancer or not. There are certain things that we look for in these nodules that make us more suspicious that it might behave like a cancer or maybe a cancer. And then if we think that something is benign, it doesn't necessarily mean that there's never a chance that another cancer doesn't form, but it suggests over time, if we're following it, that it may not necessarily be cancer if it stays the same over many, many years. And sometimes we have patients that we've followed actually for years looking at the same nodule and not seeing it grow. And so immediately intervening in some of these small nodules actually puts the patient at a higher risk for a complication than may be necessary. And so that's why it's important that they talk with their physicians, they talk with their either medical oncologist, surgeon, or radiation oncologist to decide what the best course of action is. And there are some difficult cases where we actually get together as a group and we discuss this not only between ourselves, but also with our colleagues from radiation to really get a better idea of whether or not that's a risky nodule or less so.
We have one last question, and this one is from Rachel, who asks, why is lung cancer the #1 cancer death in the United States? Dr. Puri, can you start?
I think there are two reasons for that. One is the prevalence of smoking, which fortunately has been declining steadily over the last several decades. So in general, that has contributed towards a significant proportion of patients being diagnosed with lung cancer. So at one point in time, more than 30% of the population smoked. That number is now less than 20%, but still is a relatively high number. The other reason why we have so many lung cancer deaths is that, unfortunately, lung cancer tends to be a relatively lethal cancer when you look at cancers. Lung cancer leads to more deaths than the next three most common causes of cancer-related deaths, which is colon, breast, and prostate put together. And the reason why we have so many lung cancer deaths is that it is often diagnosed at a higher stage. So of every 100 lung cancer patients, less than 25 of them are diagnosed at an early stage disease where the treating physicians can offer curative therapy and potentially just completely either remove, radiate, or however we would treat the cancer would render them cancer-free. And with more patients being diagnosed at a higher stage, it unfortunately leads to greater cancer mortality.
Dr. Herzog, is it just the sheer numbers, behavior, treatment?
So I think the reason that lung cancer dominates the incidence of cancer in the United States really goes back to smoking. If you go back to the early 1900s, the incidence of lung cancer in the United States was actually fairly low. And then if you look with the expansion and the use of cigarettes over the course of the next 40 to 50 years, you started to see this slow increase in lung cancer deaths or development and deaths. And then as you started to see the drop in cigarette smoking, like Dr. Puri mentioned, you started to see that started to decline. Now there's a delay in that, right? Because as soon as you stop smoking, as soon as the population slowed down smoking. There was a delay in the people who were still smoking. They were still generating cancers. And so as that has shifted, we've seen this decline. I think one concerning thing is we have seen a slight uptick in younger patients or younger people, either picking up smoking or picking up vaping. And I think that is concerning. My hope is that we're able to understand why they're doing that and then try to reverse that course. Because otherwise, my concern is that in 20 to 30 years, we're going to be facing an increase in cancer-related death or lung cancer development and cancer-related deaths. So.
And Dr. Herzog, I'm glad you mentioned vaping in young people, because there certainly is the sense, we know that young people say, well, at least I'm not smoking cigarettes, I am vaping instead. And we've talked about that tonight, that there's some things we know and some things we don't.
Right. And I think that's our concern, is we would prefer for them to avoid that risk, or that potential risk, until we have more information on it.
Dr. Lee, who has given us the marketing campaign of the year, Wonder Drug, Smoking Cessation. Can you wrap things up for us tonight?
Sure. I think there's a lot of reason to be hopeful with what treatments we're able to offer today for patients who come in with a newly diagnosed lung cancer. But I think there are things that you can do even before you walk into our clinic. And like you said, I think smoking cessation, changes in behavior, whether it's vaping or chewing tobacco, those sorts of things that you can do at home. There's reason to believe, and very good data to show, that altering those sorts of behaviors can improve your chance of not only not being diagnosed with lung cancer, but also if you do end up getting diagnosed, that your outcomes tend to be better.
Well, that concludes this really interesting discussion tonight. I want to thank our panelists for taking the time to join us tonight, although virtually, still a great discussion. Dr. Avaram Puri, Dr. Brett Herzog, and Dr. Jason Lee. Thank you each for joining us this evening. And a reminder that the resources discussed this evening will be included in the follow-up email to all of our registered viewers. And great news, our Learning with National Leaders series will continue this year in 2022. We'll have more information on the next event coming very soon. As always, thank you so much for joining us.